diabetes and disc degeneration, unfortunately, go together quite effectively. So there are several aspects of both disc degeneration and diabetes that are seen just because of some of these situations that happen with people. So aging, obviously, you've got that association both directions. If you have abnormal mechanical stress loads, this is more of the disc side, but it's also something that is related to diabetes because most of this is your weight, right? And because of weight, it changes those biomechanics. And because of that excess weight, you have a higher risk of diabetes. Next one, metabolic disorders. That's just kind of those metabolic disorders are, one of them is diabetes, but they kind of interconnect together, and then they impact that disc degeneration. And unfortunately, a high glucose, high fat diet, is going to both accelerate disc degeneration and increase your risk and severity of diabetes. And this is because of adipose tissue accumulation. You've got that abnormal glucose metabolism that happens that gets worse as those dietary factors are continually in play. And then inflammation. A couple of statistics before I forget. We all know that diabetes is pretty prevalent. There's about 15% of the population that has diabetes. About 8% don't know they have diabetes. And when you're looking at patients that are over the age of 65, it's about 1 in 3 has diabetes. So, taking the all adults at 15% and then adding that age factor on means a lot of the people that we're seeing every day, because they're also those people who are having trouble with their spine, are diabetic. So whether they know it or not, or whether they have it under control or not, it's something that we all need to be aware of and consider. So in looking at some of the research with diabetes and disc degeneration, we have average higher Fuhrman scores seen in people with diabetes. This is particularly noted in individuals who have poorly controlled diabetes, and then in individuals who have had diabetes for more than a decade. And that association seems to be pretty consistent. There's also an association with disc height and type 2 diabetes, so being aware of that is important. We don't know how much this is a direct causal effect of the diabetes with the disc degeneration and how much of it's a factor of the fact that their BMIs are typically higher. There was one study that showed that there was just a strong, just the diabetes impact is going to make a bigger difference. And then there was another one that they did a twin study, and that BMI factor kind of weeded things out, that the diabetes wasn't an issue. So basically we need to do a little bit more research to figure out what exactly that relationship is. We do know that people with diabetes have discs that are much stiffer, and they're more resistant to deformation. So because of that, that mobility is decreased in each of those discs. And then obviously there's an increased risk in perioperative complications. So for these individuals who have diabetes, disc degeneration, require surgical intervention, be it a discectomy or a fusion or whatever, their risk of all of those complications that can go along with surgery is much higher, just because of the fact that they have the diabetes and the disc degeneration. So I really love disc nutrition. It's fascinating how we can have this tissue that has so few cells and so little blood supply, and it still functions and lives, but it also means we have to be kind of careful, right? So you have, this is just a nice little reminder of what a healthy disc looks like. We've got that blood supply that's very external. It doesn't go down into the disc, and so we need to take care of that blood supply because that's what we've got. We also need to take care of those discs because you've got this massive tissue and 1% of it is discs. That's not very many, or 1% is cells. Apologies. So 1% is cells. That's not very many cells. So we want to be careful to take care of those cells so we can keep the disc healthy. But when we have disc degeneration that can be induced by glucose damage, we end up causing damage to the cartilaginous end plate, to the nucleus, to the annulus. All of those tissues are damaged because of the impact of glucose, and we'll talk about some of those things that go with it. But a few things to consider are it decreases the mitochondrial membrane potential just by virtue of having that extra glucose in the system. Accelerates cell apoptosis and senescence. So we've got those few cells that are dying earlier and getting a little bit older, a little faster, and we need to take care of them. And then you've got an increase in reactive oxygen species, which also causes damage. So you've got this lovely little system that's really kind of precarious, and then you add a whole bunch of glucose on there, and you make it much more precarious. So there was a paper that had a really great image in just a comparison of what a spine is looking like just by virtue of the fact that they've got diabetes as compared to a control. Very similar weight. Both of them, the BMIs were 19. It's not like these were both obese individuals. They're both normal weight, healthy as far as other lifestyle factors. But this individual, whose image is over here on number A, has had diabetes for 12 years. So if you note the Fuhrman grading on all of those discs, and you note the fact that you've got, some excess degeneration, disc height loss, this is just because they've got the diabetes. So it's just kind of a good indicator of this really does make an impact regardless of everything else. And this individual, their A1C was like 7.2. It's not like they were running an 11 or a 12. This is they've got diabetes, but it's in okay, relatively decent-ish control, but they've still got all of this disc damage that's happening. Thoughts that you have as you're looking at this and considering people that you may have worked with?
First question, actually, didn't want to interrupt you, but you said 8% of people have diabetes that don't know about it. Is that 8 of the 15% that currently have it? That's another 8%. I thought that statistic was tough.
Yeah.
15% currently diagnosed, another 8% of the population undiagnosed, underdiagnosed, whatever that would be.
Yeah.
And that's a little scary slide right there.
It is a scary slide. Yeah. And it's something that, you think about, a lot of people don't have an MRI of their spine if they're not currently experiencing pain. And if they've got diabetes, they don't know that, one more aspect, they're busy thinking about, oh yeah, I'm supposed to keep my diabetes under control so I don't get all these complications. They don't think about their spine as that list of complications.
I was just thinking about the biomechanical difference between dealing with one segment or a couple of segments that are degenerated and trying to restore them back to health versus an entire spine full of discs that are biomechanically degenerated, and what a much more challenging problem that is.
Exactly. And, having Fuhrman scores of 5 on all of your discs is not cool. So a few details on exactly what this extra glucose is doing in our bodies if we've got diabetes that's uncontrolled. One of those things is that you're increasing atherosclerotic damage. So if you remember back, some of you talk about this more often than others, but when you've got atherosclerosis developing in the blood vessels, it's a combination of inflammatory damage and then lipids floating through, getting stuck. We've also got sugar floating through and getting stuck and increasing that inflammatory damage. So with diabetes, you've got that extra sugar floating through the bloodstream, and it's going to increase the rate of that atherosclerotic development, which the problem is then think about that blood supply to those discs, we don't have a whole huge ton of blood vessels going there. So we're damaging those blood vessels. The capillaries at the end of those blood vessels will thicken because of that atherosclerotic process, and then they break, and then they don't work right. So you've got some leakage that's happening. That's not good nutrient transport. And you've also got that thickening damage where you can't have transport. And so that blood supply to those discs is basically can be eliminated if you get too much damage, but you've got a much lower blood supply. We also get oxidative stress that the glucose will cause, and basically that oxidative stress means our cells die earlier and die faster. So you've got less nutrients and more cell death, and then what happens to your discs, right? So there's another impact with the sugars. Have you all heard of advanced glycation end products? Like, been a long time for some people maybe, but yeah, vaguely back there. So essentially this is when you've got proteins and fats that sugar's attached to, and then it changes those proteins and fats. And this happens in diabetes. So this can happen to food that we eat, and this can happen to tissues and proteins and lipids in our body. And both of those have an effect, and then they both have an effect on our discs. So the one that you probably think about most with food is what's called the Maillard reaction. So this is that browning that you get when you make toast or when you grill meat, things like that causes that color change. But that's sugar getting attached to proteins and lipids. The one that you are all totally familiar with, but probably haven't thought about, is hemoglobin A1C. So you've got those hemoglobin molecules, and the sugar's attaching onto those hemoglobin molecules as we're going through the blood. And we use this as a great tool to diagnose someone's level of severity of diabetes or their blood glucose control over that 3-month period that those blood cells are alive. But this is just an example of one of those kind of reactions of that advanced glycation end products. Unfortunately, just like other challenges that we have as we age, we get more of those end products as we get older. And when you have chronically elevated blood glucose, you also have more of those end products being produced. So the problem with the disc is when you've got more of these advanced glycation end products, they're deposited in that disc. And remember what we said about the blood supply? We don't have a whole ton of it. It's hard to move those out of the disc. So basically they're just staying and they're accumulating and they're causing more damage. Then you've got diabetes and whatever we're eating attached on top of that, that accelerates that rate, and we can damage all of those different disc tissues. So then you get oxidative stress, inflammation, altered protein activity, hardening of the tissues. It changes the biological function of some of those proteins. If you've got a sugar attached to it, it doesn't work the same way. Future spread of reactive oxygen species, you know, how those kind of cascade through. So you've got that all contained in that disc, and you end up with that disc degeneration. So another thing to consider is GLP-1, which is glucagon-like peptide. And this is one of those things that's a really, big hot topic right now. So what's the impact on disc and diabetes? So basically, because it's going to help regulate insulin, it's going to help regulate that glucose, and you're going to decrease the amount of sugar floating around in the blood to cause damage to the capillaries, to cause that increase in those advanced glycation end products. And so it can help make discs less likely to have that degenerative process happening because we've got less glucose floating around in the blood. There's another side effect that also happens. It also can help dampen the receptors for those advanced glycation end products, the factors that induce the inflammation. So instead of having those end products being just attached onto the receptors, you decrease that receptor response, and so we don't have as much inflammation. Liraglutide is the one that's been studied mostly with looking at disc and disc degeneration, and it seemed to be protective of the apoptosis effect that can happen in the disc cells. So this can be a really helpful tool, right, for people. And along with controlling their diabetes, help slow the rate of that diabetes-induced disc breakdown and degeneration. So, wanted to talk about a person for a few minutes that was able to work with a little bit in clinic. So this is a 47-year-old male, 74 inches tall. His weight last August was 250 pounds. In February it was 230. And then in June it was 249 again. So his BMI went from 32 to 29.5 to 32. High in the obesity level, not like crazy high. His A1C was 9.4. In January it had gone up to 11.3, and then February, about the same time with that weight loss, it was down to 6.8. So what do you think he was doing in that time period where those numbers went down? Elephant in the room. He was on Ozempic. Okay. But because he was on it and taking care of himself, eating right, exercising, he was doing awesome. He was feeling good. His wife said he was better than he had been in 20 years. He was feeling great, like, you know, world is my oyster kind of great. Everything was awesome. And then insurance stopped paying for the Ozempic, you know. And then he had surgery, and then he just kind of crashed off of that whole taking care of himself because he'd had his discectomy, he wasn't hurting anymore, and insurance won't pay for the Ozempic anymore, so, you know, life's kind of lame, but oh well, I'll go back to the status quo. So what are your thoughts on how to help someone who's in this situation and how to help them understand that, you know, he's probably up for another disc challenge in the future?
Again, back to the elephant in the room. From my experience with Ozempic, yes, it does help you lose weight, but if you're not making the lifestyle changes along with it, as soon as you stop Ozempic, you go right back to those old habits and you gain the weight back. So I think it's extremely important with any of our patients that are taking these weight loss medications that we remind them and we push them to make actual life-changing habits, because there's a lot of complications with Ozempic that they're finding now as well, and it does help with our diabetic patients, but if they do not have those lifestyle changes, those daily habits of exercise and watching what they're eating and making sure that they actually are changing the way that they live life, basically, then we can have complications that arise and they'll gain that weight back, and then he'll be right back in to Dr. Edwards in another 2 years because of the same exact thing, or back into you saying what's going on. So exactly. I think it's just important that we're making sure that our patients understand this isn't, yes, it is a drug that helps with their weight loss, but it's not the end all be all, and you don't have to do anything else to make lifestyle changes.
Yeah. Yeah, he was one of those individuals that I had concerns because he was like, oh yeah, I can do this, I can eat well, but it was not I'm making little gradual changes that will stick. It was yep, I'm doing everything perfect. And that was the Ozempic talking. It was controlling his cravings. It was helping him to be able to basically feel lousy so he didn't want to eat. And so, you know, you have to make those little changes. And then there's the whole insurance doesn't reimburse for nutrition counseling well, and after a couple of visits they're like, yeah, I don't want to pay for this anymore. But all of those factors that you mentioned are important to help people understand. Other thoughts?
That's an impressive medication. I mean, it's hard to argue with that. In 6 months, his A1C went down almost 3 points.
Yeah.
That's impressive. So if we're going to keep seeing that, it's going to get used because it works, and he felt better, and he did better, and it's objective.
Yeah.
Hmm.
And I love the way that those medications do help with the blood sugar control, because it does help make such a big impact on those complications. If we can keep that blood sugar down, then people are going to have a healthier body. So whatever the tools are, and those GLP-1s should be as an adjunct to metformin, right? It's not the first line, it's second line. We need to use that combination, but if we can use that combination, it can be very effective.
Do you have A1C numbers from June when his weight was elevated again? Are they right back up?
I don't. He didn't have them checked at that point. And in that June visit, he had stopped seeing me. It was just me flipping back and saying, I wonder how he's doing. And he'd come in for his post-op, and that's where things were, but he hadn't gotten a new A1C checked. May not have wanted to. So, big picture messages. When we have someone with diabetes and back pain, first of all, we want to start by helping them control their diabetes, because it's an easier first step to get them in a better place and control. It's a little bit harder to control their back pain, right? It takes some of the same work to control both of them, so you're kind of hitting both at the same time. But if you can say, let's focus on your blood sugar control, that's something they can feel like, from one day to the next, they can control a little bit better. And if they can understand that if they're controlling their blood sugar, they're going to decrease that rate of disc degeneration, that's kind of inspiring, right? It's like, it's like the visit when they go in and find out what their kidney function is, and it's suddenly like, oh, maybe I should have been controlling my diabetes because I don't want to go on dialysis. This is another one of those things, hey, my back hurts, I don't want this to get worse. Let's do something about it. Recognizing that interconnection between discs and that diabetes. So looking beyond their immediate problem of, yeah, we've got this disc that's looking not good. Yes, they've got back pain, but let's look at the whole picture of what's going on and how they're doing, and look at those other levels, because it may not be just that L5S1 that's causing the pain and the problems. Looking at that whole spine to say, okay, so are they getting some degeneration at all these other levels that's just not showing up as much? And we need to keep that under consideration as well. And because of that, imaging is key to being able to recognize and understand what's going on, and that it's not just, oh yeah, I've got some back pain. It's, let's see what all of those discs are looking like. And here's the hard but easy answers, right? So we need to make sure with everybody we're evaluating their lifestyle, whether or not their A1C shows that they're diabetic. Someone who's in that pre-diabetes range could be having some disc degeneration happening. Someone who is living a lifestyle that, yeah, maybe they've got an awesome pancreas and it's doing its job, but they're eating really poorly and they are still causing that atherosclerotic effect and having challenges that they are not seeing. But recognize that high sugar, high fat diet not only damages the discs, it damages the ligaments and other body tissues. Lifestyle changes, so diet, exercise, sleep, stop smoking if they're smoking, use those oral medications. They can be helpful just in the keeping that sugar down to prevent that further disc degeneration. And then the GLP-1s, if those seem to be warranted for that particular individual. Okay, so now since I screwed up your barbecue by talking about advanced glycation end products, we're going to end on the how to fix it just a little bit more, so you're not all thinking, oh man, I can't grill my meat or I'm going to die of diabetes and disc degeneration. So keep your grill clean. Use thinner, lean cuts of unprocessed meats. Grill over indirect heat. Grilled vegetables, even better. And then serve it with a big salad, so you're not having just a massive amount of, this lovely caramelized, delicious meat, right? Thoughts? And who's having the barbecue tomorrow, so we can all know whose house to go to?
Just kind of anecdotally, I feel like I've seen patients that come in, gone through those transformations of losing 100 pounds, where they've put in the effort and they've taken care of themselves, but then they come to the clinic and they say, I actually have more back pain now that I've lost 100 pounds. Do you have any thoughts on what and why that is?
So the thought that jumps in is they've adjusted to very different biomechanics with all of that weight, and now that that weight is gone, that's shifted, and so they're putting pressure on discs in different places, they're putting on pressure on ligaments in different places. You want to respond?
Oh, I was just going to say they're doing more.
Oh, that's true.
They damaged their discs and their spine earlier. Now they're just living a better lifestyle, but the previous damage takes a while to.
Tyler?
Yeah, I've always thought about it as not getting so objectified by the numbers. So a patient might come in and say, well, I've been eating just 1 meal a day and fasting the rest. And like, there's this balance. Like, you want a person to lose weight, but you also want them to maintain muscle mass. So if they're just starving themselves, obviously they're not going to be having those internal stabilizers in place to support the spine. And much what you spoke of, the biomechanics are going to be disrupted as a result of that. So making sure they understand proper weight loss.
Yeah. Anybody that comes in and tells you I'm eating 1 meal a day, it's a red flag, and they're likely, they think they're doing intermittent fasting, which they are, but they're 6 months, they'll probably lose some weight, and then they're going to stop, because you can't nourish your body effectively that way. And most of them are not eating a healthy 1 meal a day. It's I hit McDonald's at noon, and that's my meal every day. So
I just think that one of the big hardest parts for our patients is there's so much misinformation out there, right?
There is.
So I think as clinicians, like, if we're seeing this in our patient population, we need to make sure that we're setting the record straight, that we're educating them on proper nutrition. And if we don't know, then we have you as a contact, or we have whoever we need to, but we make that phone call and say, hey, I've got this patient, they're going through this, what would you recommend? So that at least in our population that we see, the record's set straight. That misinformation is not there. Like Tyler said, I mean, you can lose a lot of weight, you're losing muscle mass with it, you're gonna hurt. You're gonna be unstable. So our patients need to understand that there is a proper way to lose weight and to get the resources that they need to help them actually do it in a safe and effective way. And going back to those lifestyle changes, a lot of people like to lose the weight, but they don't like to change the lifestyle. But it doesn't work that way. It needs to go hand in hand to make sure that their body is well taken care of across the board. And you have the flip side. There's some people that we would consider obese that are actually in extremely good health.
Definitely.
And so you can't judge it all by just like the BMI and about what they look like, because everybody's bone structure is different, everybody's muscle mass is different, and so you have to take it on an individual patient by patient basis, get rid of the misinformation, and treat that patient individually.
Definitely. Thank you. And I would love for you to all teach all of your patients about good nutrition, so please, and if you have questions, please ask. But yeah, because it makes such a huge impact on life and longevity, and it should be so easy. I mean, it's not, but it is. So, all right. Thanks. Appreciate you guys being here.